Perfect. So Rebecca and Jennifer say everything sounds good. So I think we should go ahead and get started, everybody. Thank you so much for joining us. I think we've got a few people that are live with us, and hopefully more will join. And I think a bunch more people are watching. Welcome to, I don't know, number 8 or 9 of Burning Migraine Questions, episode 8 or 9. This is going to be a little different. Hopefully with some really important content, as I think it almost always is, but slightly different format. It's not just going to be me answering other people's questions. I thought we would do and trial a new kind of two-person interview type format. So this is going to be a little bit of an after the final rose type of show. Much like on The Bachelor, because hopefully some of you that have joined us and some of you that are watching saw the doctor's episode that featured Ronny Ead, who is actually a patient of mine and is joining us today. I thought it would be a really interesting thing to have him on to go over a couple of points that I think were not addressed, because of course you can't address everything in a 7 or 8 minute segment, whatever it was. But also, I think a lot of people don't know, Ronny, that the show was actually videotaped almost a year to the day. I think it's a year tomorrow, in 2018. And so it's been quite a long time since you had that second procedure with me, and you were a couple weeks afterwards. So first of all, thank you for joining us. Thank you for taking the time to join me on the show, and thank you for taking the time to be with us today and help answer people's questions. But I think probably one
Yeah,
of the first things
of
people
course, I'm happy to
know
be
is,
here. And
yeah. So one of the first things I think would be worthwhile saying is, how are you doing? I mean, it's been a year, like I said, since the show actually taped, and you were doing well then. What's going on these days?
sure, sure. Pretty much immediately after my first surgery, which was well over a year ago, it was, 16 months ago, I felt an immediate, a huge amount of relief. And then the show was filmed about 4 months later after my second surgery, and I felt even better at that point. After we operated on the front, some of the residual pain that was still happening there was immediately better overnight, essentially. And a year after that, bringing us to today, I'm not only am I still between 90 and 100% better, depending on, the week, basically, but, my lifestyle has gotten way more intense this past year. And
So
my
yeah, tell us
level
about that.
of,
What are you doing now?
um, sure, sure. So prior to surgery, my lifestyle was kind of really, it was designed to be really chilled out, designed to be really low stress, designed to not, designed basically around protecting me from getting headaches. So at that time, I was in a community college automotive technology program, which was really light in terms of workload, really low stress. I basically just went in and hung out with the guys every day and, joked around. It was really a lot of fun. And I was doing that until May last year, which is basically the month after my second surgery. But since then, after I became cured of the headaches, I decided to pursue something that I really wanted to do, which was obviously a lot more intense. And that's I'm in a pre-dental program at Tufts University in Medford, taking some really intense science classes to give me the prerequisites that I need to be able to apply to dental school. So my lifestyle now is, 8 to 10 or even 12 hours a day of really hardcore science coursework, leaned over, a notebook or a book, doing chemistry problems or, cramming biology slides just for ridiculous hours a day. And I've been doing that since September 2018, so for about six or more months now. And through that really rigorous lifestyle and high stress, I should add, not just physically intense where I'm leaning over, and cranking my neck, which normally would trigger a headache pretty much immediately prior to surgery, but, mentally stressful, this fear of failing exams, this fear of maybe not getting into dental school or something like that. It's a very high stress lifestyle. And in spite of all the stress and all of the physical strain on my neck, the headaches are still, between 90 and 100% cured, which is ridiculous.
Right. So obviously, first of all, congratulations on all of that success. I think you're obviously doing something that sounds like it's certainly more intellectually rigorous and perhaps as physically rigorous as you were doing before. Still doing well from a symptom standpoint. Um, the headaches that you still do get, are those 10% of the same kinds of headaches you used to get in the past, or are those, would you say, headaches like, we would imagine most people get at some point in their lives? You get a headache, you're dehydrated, get a headache, you didn't sleep well last night, that kind of thing.
Right, right. Well, to compare the headaches that I still get to the headaches that I got before surgery, the headaches were super localized. They would always start in a very particular place. And then, so for example, here in the back of my neck, and the headache would start, usually I would wake up with it, and then it would intensify and it would grow from like a 3 or a 4 out of 10 in this one spot to an 8 or a 9 or a 10 out of 10 by noontime, spreading throughout the entire head, temples, forehead, eyes, and then even across to both sides of the neck. Was typical for headaches prior to surgery. Now I still usually wake up with the headache. If I do, maybe 2 or 3 times a month, I'll wake up with like a 2 or a 3 out of 10, and probably half the time I will not take any medication, and I will just kind of drink some coffee, which, prior to surgery, I never dared to drink coffee, by the way, and now I drink a pretty heavy amount of coffee. Oftentimes I'll just have my morning coffee, and that'll be it. So it's hard to say whether or not that's even a neuralgia type headache, or whether it's just me, having a coffee withdrawal. But so the headaches that I'm still getting are way less intense, and they are way easier to abort. And a headache that doesn't respond to like a coffee dose, I still do carry triptans. So I have, like right now I'm using Maxalt. I have the little 10 milligram melts, and I usually break one in half. And if I really don't even want to bother with the pain at all, then I will take a half of a Maxalt, and within an hour, guaranteed, it's good as new.
Okay, yeah. So it's obviously, certainly, if you still have symptoms, they're much more manageable than they used to be.
Sure, sure. And by the way, that's about probably twice a month that I will do a dose of triptan.
Yeah, yeah. So that's terrific. Again, really good result there. Obviously, one of the things that you said, I think that is just really important, and actually dovetails with an important question that one of the people responding to one of the posts about the show had asked, and that was because you'd mentioned neuralgia pain, and what is neuralgia? It's nerve pain. So neuralgia. Is nerve pain. The question always is which nerve is causing the algia, and then if you can figure that out, can you do anything about it? But again, this brings up the point that this one commenter was making, which is on the show, how come they didn't mention the term occipital neuralgia or trigeminal neuralgia at all? And they were only talking about migraines. And I wanted to touch on that very briefly, and feel free to obviously jump in at any point, but I think this is a really key sort of overarching theme that we need to talk about and discuss when we discuss what we're doing with regard to surgery. The interesting thing about this is, in reality, what is the term migraine? And by the way, I think they did a phenomenal job on the show. There's really just so much to say about this topic and how it's treated by the medical community in general and classically. So there's only so much information that you can convey in the 7-minute show, which I think they did a remarkably good job of. And I think you were fantastic on there and really conveyed a lot of information specifically about how, if you can fix a lot of these issues, how it can change your life. And I think you did that, very eloquently. as you're doing today. But
Thank you.
let's talk about what is a migraine. I think if you look at the definition of migraines, and I actually checked this yet again just before this episode on some of my databases. The thing about the term migraines is that it's a very generic term. In other words, it's a neurologic condition that has a lot of characteristics that are typically, not always, but typically associated with it. It occurs this often, it is this severe, it is 3 times more common in women than in men. It may have an aura. The aura may be, this symptom or that symptom. It is typically one-sided, but not always one-sided, et cetera, et cetera. And yet, when you have all of these descriptions, the questions that always come to mind are A, okay, so you understand that. Can you figure out what's causing it? And if you can you do anything about it? And that's the difficulty that I have with the term migraines, because if you then look at those same sort of summary articles that just described all these characteristics, and you look at, well, what causes migraines? What's the underlying pathology? The simple answer is we don't really know. There's a lot of theories out there, and I've said this to you as well as all of my patients. It's neurons that are firing abnormally, kind of like epilepsy without the seizure. That's called the cortical spreading depression theory. There are all sorts of chemicals that may be all cattywampus in the brain, like serotonin, hence all the triptans, or calcitonin gene-related peptide, hence the new CGRP receptor antagonist class of drugs like Aimovig, Ajovy, Emgality. Blood vessels are dilated when they should be vasoconstricted, or vice versa. Those are all these theories, but the simple answer is we don't know. And unfortunately, what ends up happening because we don't really know is that people are treated what we call empirically. In other words, it's like, all right, you've got migraines, here, try this drug. Oh gosh, that didn't work. Well, try this other drug. Oh shoot, that didn't work either. Here, try these 2 together. Oh darn it, try that with massage, stress management, meditation, dietary manipulation. And you had mentioned that in your in your prelude to the show, which I thought they did, again, a really good job of sort of describing. And what you're really trying to do in that sense, when you say someone has migraines, is you're trying to right the chemical wrong that you presume is going on inside their brain. But you don't really know what you're trying to treat, and so you just kind of throw in a little bit of a dart at the dartboard kind of thing. Now, that's not to poo-poo neurologists or people that treat people this way, because that is actually the most common way to teach how to treat migraines, and I suppose it works for many, many people. But it's such a prevalent problem, 36 to 37 million Americans, that there's going to be a significant subset of people that don't get relief. And you and I were discussing a couple of things that have been happening with you recently, and I want you to touch upon that, because you said you'd recently been to a conference on facial pain. And tell me what the conversation was there, because one of the neurologists that we won't name, who I think is a very bright guy, was involved actually in some of the pivotal studies on getting the triptan medications approved in this country many years ago, and is a very well-researched, very bright neurologist that I've been on a panel with, actually. But tell me what the general gist was in terms of what they think causes, quote, migraines and facial pain.
Sure. So I was attending the 5th annual symposium of headaches and face pain at the Tufts University School of Dental Medicine. It's an annual conference they run where they bring in, it's a continuing ed course for dentists, basically, where it's run by the Tufts Craniofacial Pain Center, which is basically an interdisciplinary team that includes neurologists and psychiatrists and dentists who treat very hard to diagnose, previously impossible to cure issues of face pain and headache. And I had been a patient there actually in 2017 before I met you. And so this was actually a 2-day conference, and there was one single mention in 2 days of a potential mechanical cause of headache pain. And that was headaches that may be arising due to compression of nerves in the temporomandibular joint, which they refer to as the various temporomandibular disorders. So the only mention of mechanically caused headache pain was relating to this area here. There was absolutely no mention, in this cutting edge headache symposium of the potential for compressed nerves in this region or in this region or in this region to be triggering headache pain. Most of the discussion focused on various types of pain meds to treat different types of headaches. A lot of the discussion revolved around classifying and categorizing different types of headaches. And then a big portion of the conference was dedicated to the new CGRP drugs. And it was bizarre because, as I was telling you yesterday, there was actually a neurologist who gave a presentation on these nerve blocks that he does to treat headaches in some of his patients. And he basically was teaching the dentists how to do these different nerve blocks. And they were all the same nerve blocks for all the same nerves that you blocked on me when you were determining my candidacy for migraine surgery. So he was talking about how he blocks the lesser and greater and third occipital nerves, and how he blocks the various nerves in this region, and how when he does so, he brings immediate relief to his patients' headaches. But that was it. That was the end. The point was these nerve blocks are a way to bring immediate relief to patients. There was no discussion of, oh, well, what does this mean for headache surgery? There was no discussion of, oh, well, is there a way to make this relief permanent by surgically relieving, decompressing these nerves, which are obviously the cause of the pain that the person is experiencing. Because if the nerve block eliminates the pain, that means the pain was coming from the nerve.
Right,
so
exactly.
Point being,
yeah, no,
go
and
ahead.
so I think what you're saying, I think really just highlights sort of what I was trying to get at. So I think to answer the person who had commented on the thread about the show, why didn't they mention occipital neuralgia? The fact of the matter is your presence on the show is a perfect example of neuralgia, nerve pain, that is diagnosed as a migraine. Now, technically, that's not inaccurate because, yeah, you were having headaches that often. You were having headaches that were that severe. You were having a lot of the symptoms that would classify or fall under the category of migraines. But that would be, so technically that's accurate, but it's very non-specific, okay? And I should say it's not accurate, it's not wrong, but it's not specific enough, because saying you have migraines in many cases is kind of like saying, well, geez, Ronnie, I think you have cancer, but not telling you what kind of cancer I think you have. Because if you have testicular cancer, that gets treated differently than if you have liver cancer or kidney cancer. And so when my answer to this person was, we did mention occipital neuralgia. They just didn't use those words, because so many people that are diagnosed as having, quote, migraines actually have neuralgia, okay? And then the question becomes, okay, which nerve is causing the algia? And as you pointed out, the nerve blocks are actually really great diagnostic tools. They are not treatment modalities, because like any medicine, when the nerve block wears off, the pain will return. And so I think it's great that dentists or other pain management physicians or neurologists will do nerve blocks for a patient who comes in the office in extreme distress. But and if they make them better, that's wonderful. But now the question is, well, what do you do with that information? Because at some point, just like when you go to the dentist to get a filling, at first your lip is numb and it feels like it weighs 1,000 pounds, and then they can drill and fill whatever they need to do to fill the cavity, but your lip's not going to be numb forever. And if the numbing relieves the pain, when the numbing goes away, the pain's going to come back, because the underlying problem, which is a mechanical issue on one of the nerves that they numbed, is still present. And that's what ultimately needs to be treated to give you that similar level of pain relief on a permanent basis, and ideally, in most cases, without the numbness. And I think that, when people come to see me and say, doc, I've been diagnosed with migraines. How come nobody talks about neuralgia? I think the other problem is that migraines is has such a broad definition that almost anything, any kind of headache can fall into the category of migraines. And the exact opposite is almost true for the term occipital neuralgia, which has so many specific criteria that you have to meet to actually fall under the category of occipital neuralgia, according to some of the neurologists who just want to subclassify everything, that if you don't fall into that category, by definition, you don't have neuralgia, as if everyone is going to, you know, feel everything in the exact same way. I mean, headaches and pain in general is inherently a subjective phenomenon. So what you might perceive as a 10, I might perceive as a 2, or vice versa. You know, this painting behind me, some people will look at that and go, oh, it's beautiful. I see this, I see that. Other people will be like, yeah, it looks like somebody threw up on a canvas and it's just this splotch of paintings. This is ridiculous. Just my 3-year-old can do that. And so there's no way to classify that. But the flip side is also true in that because you have to meet so many specific criteria to get a diagnosis of neuralgia, or occipital neuralgia specifically, so few people are actually given that diagnosis, which might actually point them to a permanent treatment, which could be surgery. And I think that's really hard. And when I talk to my patients about this, I say, look, it's not that people don't know what occipital neuralgia is, it's that it's incredibly, incredibly, incredibly underdiagnosed, which is really too bad, because certainly at this point, there are treatments for it. Now, I think one other thing I wanted to touch upon, yeah, go ahead. Did you want to make a comment?
Just to relate a little bit more about the experience I had as a patient before I had met you. Mm-hmm. So all my life I had been told that my headaches were chemical in nature, and I was open to that idea. Mm-hmm. And so I did everything possible to try to fix the chemistry that might be causing those headaches, right? Like I was a perfectionist about food and about toxins entering my body and about sleep and about all the different potential chemical triggers of headaches. And when I perfected all of that, I was still having headaches. Now, I was also in the back of my mind thinking, okay, well, maybe there's a mechanical or structural cause to these headaches, because I had been noticing, as long as I was having headaches, that there were often postural triggers to my headaches. So, for example, a long bus ride, or there was my injury in 2011 when I threw a football, and as soon as I threw the football, I tweaked my neck right here. I felt like a lightning bolt in this part of my neck, and then I had a headache for the next month straight. So for years, I had been kind of building a case. Okay, well, is this chemical or is this mechanical, structural? And by the time I really went on this mission to meet with doctors, this began in 2016 when I started really being proactive about trying to fix the headaches, because for the several years prior to that, I was basically living in a monastery where I didn't really have access to medical care. And that it was during that period that the headaches got much worse. So by the time I started seeing doctors, I was pretty much already convinced that the headaches were mechanical in nature. I knew that there was something going on in my neck. I could actually point to the very specific places where the headaches would start and where they would be centered on. And I would go into the doctor's office, whether it was the neurologist or the dentist or the osteopath or the primary care physician or any of the other health, or the physical therapist, any of the other health professionals that I saw to help me with my headaches. I would tell them. I wouldn't tell them I had bad headaches. I would tell them, I'm getting headaches. I'm waking up and there's pain. As soon as I wake up, the pain is right here. I mean, I would literally tell them that. And still, I would leave with a diagnosis of chronic migraines. So this issue of missing the diagnosis for occipital neuralgia or any diagnosis of a mechanical cause for the headaches, whether it be occipital or trigeminal branch neuralgia. Um, this is a problem. There's some paradigm shift that needs to occur where health professionals become more aware of these mechanically caused headaches.
Right. Yeah, no, I appreciate that, and I think that's again so eloquently said. You know, in some ways, I think that's what one of the barriers to sort of a wider acceptance of this concept has been, and yet it is occurring because it is a paradigm shift. If you've been told your whole life that you know, the Earth is the center of the universe, and then somebody like Copernicus comes around and says, "Well, wait a minute, we're just some planet circling around the sun. We're nowhere near the center of anything. We're one of many universes, etc." Everybody's going to tell him he's out of his mind. And again, it reminds me of the paradigm shift that occurred, for example, with peptic ulcer disease, where it always used to be thought that there was an acid-base imbalance in the stomach, and when there's too much acid and not enough base to neutralize it, you'd burn a hole in your stomach, you get an ulcer. Well, it turns out it was actually all caused by a bacteria, not all, but a significant number of these were caused by bacteria called Helicobacter pylori,
Right.
so that instead of cutting people's duodenums out and parts or all of their stomachs out, we now just gave them a course of antibiotics and their symptoms went away. And I remember when that concept first came to the forefront, the people championing that were told they were out of their minds. They had no idea what they were talking about. There's no way that that could actually work. And, you know, look, in some ways, I think that that's understandable in the sense that if you think that this is a really complex problem that requires surgical intervention, the idea that you could take a pill and it would just magically disappear, it's not magic, of course, but that, you know, it would really just end the issue seems almost implausible, and yet data, you know, from papers after data from other papers came out demonstrating that that was exactly the cause. And I sort of want to touch on one more thing before we then have to go. And, you know, depending on how people respond to this, and so I would ask anybody that's joined us or seen this or sending it to a friend, if you actually enjoyed this sort of interaction and this sort of back and forth, perhaps you know, you could let us know, drop us a note on Instagram or on Facebook on our feed somewhere, and let us know, and we can continue this conversation because I think it's really helpful. But you know, people are always asking me, and they touched on this on the show, does insurance cover this, and how come it's not paid for? And again, interestingly enough, Medicare covers it because we use codes like neuralgia and nerve injury, which is really what this is. And Medicare typically is the baseline for which other insurance companies use to say that they will cover something. And yet there are a lot of insurance companies and a lot of insurance plans that don't do this, and they consider it experimental. Now, the question really becomes, define experimental. At what point do you say something is no longer experimental? And, you know, there's no hard and fast definition for that. But what's interesting is that at this point in time, I think the sheer amount of information supporting headache surgery as a viable option. It's not the only way to treat headaches. It's certainly not the first thing by any stretch of the imagination that you want to try if you start to get really horrible headaches. But it's definitely a very powerful arrow in the quiver of options that you have, specifically if somebody's like yourself and they've tried so many other things and nothing is working. And as a matter of fact, and we've had a couple posts about this in the past, the American Society of Plastic Surgeons, which is our chief society, it's the largest plastic surgical society in the world, actually put out a position statement about a year ago this month in May 2018. And you can Google it. In fact, I'm looking at it right now. It's the ASPS policy statement on migraine headache surgery. I think it's a 12, 13 page document that basically states that when conventional therapies have failed, that headache surgery of various kinds, addressing all these nerves, depending on the patient, it should be considered the standard of care. And it's not just these people's opinions. They cite, and I'm looking at it right now, 89 peer-reviewed articles in support of this document. And again, this is an official document documenting an official position statement. We think this is standard of care when other things have failed. So we are starting to see cracks in the dam that says, oh, this is all hooey and snake oil. We have a number of neurologists that we work with here, as well as nationally, that have also begun to champion the idea that certainly not in every patient, but in some patients, there are extracranial, meaning outside the skull, causes of headaches. And there was actually a paper published within the last 6 or 8 months, I think it was, in cephalalgia, which again is a fancy doctor term for head pain, but it's the official journal of the International Headache Society. And it was a small study of 6 people who'd had various types of headaches and were treated with surgery in very successful results. Now it's a small study. It's really I think it was 6 patients as a cohort being followed for a certain period of time. But again, the fact that something like that is actually appearing in a neurology journal, and one that is the official journal of a major headache society, I think really speaks to the fact that at some point, no one is really going to be able to ignore the fact that when things don't work out with medicine, conventional therapies like acupuncture, massage, etc., all of which are great things to try, this is a viable option. And the fact of the matter is, I also think about something that's near and dear to my heart for anybody that's followed me online. We won't get too personal here, but if you are diagnosed with breast cancer in this country and in this day and age, and you live anywhere near a metropolitan city, you're going to go to what's called the Breast Cancer Center of Excellence. And in order to have that designation, that institution will have to have a formal meeting of the minds when people are seen there who are diagnosed with breast cancer. And so what I mean by that is they have what's called a breast cancer tumor board. And so if you have a cancer diagnosis, your breast cancer surgeon very likely is going to be the person presenting you. And then at that table, you are going to get input from not only the breast surgical oncologist, the person who's going to be cutting out the cancer in the lymph nodes. You're going to get a medical oncologist opinion as to whether you need hormone therapy or chemotherapy. You're going to get a radiation oncologist opinion as to when you need radiation or not. When should you do the chemo and radiation, before surgery, after surgery? Do you want to shrink the tumor before you take it out? What does that do to your surgical options? You're going to talk to a radiologist to say, okay, well, we've seen this on the mammogram. Do we need an MRI of the breast? You're going to have a physical therapist who's going to talk to you about what are your chances for lymphedema? How can you prevent that? What exercises do you do before and after surgery? Dietary experts, et cetera, et cetera. The fact of the matter is that chronic pain in general, but certainly headache pain, is ultimately always going to require, because it's a complex problem like cancer, a multidisciplinary approach. And so, I hear stories like yourself, and I know that you've had a lot of orthognathic and dental treatment as well. That's certainly played some role in your getting to the level of functionality and relief that you've gotten. You still take some triptans occasionally. The number's much less, so surgery has definitely been, I think, I'm biased, of course, but an important part of your treatment. But look, if you still didn't have the triptans, you might be a little less functional. If you didn't have whatever orthognathic appliances you had, you might still have other problems. And I think that, hopefully at some point we can all come together in the sense that we realize we're really all on the same team. We're all trying to make the patients like yourself better. Instead of like arguing with one another and saying, oh, what you're doing is silly, or what you're doing is silly. I mean, I try to work with all of the pain management physicians that send me their patients, and the neurologists and rheumatologists and orthopedic surgeons that send me these headache patients, because without them helping me manage whatever medication they still need to be on after surgery, the patient's never going to do as well. And it's just like the patient with breast cancer. If you just have surgery, you're going to have a certain level of survival. If you have surgery and chemo and radiation in appropriate doses and appropriate times, you're going to do even better. And that's really the goal. So anyway, I'd like to give you the opportunity to make a couple of final comments, Ronny, and then we'll sign off for today. And like I said, everyone who's watching or who's been here, if you think this is a worthwhile kind of format, please let us know, and we're happy to do this again in the future.
Sure. If I could add one more thing, I would just say that if anyone suspects that their headaches are related to, some kind of mechanical thing going on in their neck or in their head, surgery doesn't require a leap of faith. I mean, you can just proceed with the nerve block diagnosis. you can have your nerves blocked while you're having a headache episode, and that will pretty much tell the whole story. So, this doesn't require a leap of faith to proceed, and this has been a life-changing experience for me, and I would encourage anyone who feels like their story is similar to mine to at least seek out a surgeon and have that diagnosis, that diagnostic procedure done, and go from there.
All right. Well, thank you, Ronny, again, so much for all of your time throughout this whole process. I think, you're being available and sharing your story has really been helpful for a lot of people. And I know certainly have been a number of my patients, one of whom has joined us on this feed today, that, met you and heard your story and then had surgery with me and has also done very well. And we might actually have her on in the next couple of weeks, depending on how our response to this goes. So anyway, again, thank you so much for your time and your efforts and your story. Good luck with your finals over the next couple of days and couple of weeks, and you'll look forward to seeing you in dental school and great things from you in that regard in the future. And thank you everyone for joining us today. Really appreciate your time.
Yes, thank you, Dr. Peled, for fixing my headaches.
No problem. Cheers, everybody. We'll see you in a couple of weeks. Bye-bye.
Thanks for tuning in, everyone. Bye-bye.